Thank you for joining us. We're here for your annual Triage Refresher, Build a Strong Foundation. The nursing leadership team would like to welcome you to today's event. We're going to talk briefly about some housekeeping items, and then we're going to share with you some information for how to obtain your contact hours and complete your evaluations for this event. First, we would like to ask that we hold all questions to the end for the benefit of all of those who are joining us remotely. And also, for those of you that are joining the webinar, please list each participant that is joining us if you are logged on as a practice. Thank you so much for doing that. You can add your names in the chat window in the bottom right of your computer screen. The handouts were sent prior to this event that you'll have to review. If you enter your questions in the webinar, we will answer them at the end. And for those of us that are joining us in person, we will also answer your questions at the end of the webinar. I'd like to draw your attention to the next page, which is going to be how you're going to obtain your evaluation and contact hours. We are doing this electronically for the first time, so please note the survey evaluation link that is in purple. That is the evaluation which you will complete for today's event. And then after that's completed and received to the nursing department, we will then send you your contact hours electronically by email. So you have a record of attendance, okay? So there are no disclosures for today. You must sign in by the WebEx, again, listing your name as a participant, or on the sign-in sheet that's going around right now if you're attending in person. Attend the entire session, and then complete your evaluation to be eligible for contact hours. And now I'd like to introduce Jerry Karen, who's going to start today's Triage Refresher.
All right. Welcome, everybody. We're really excited about this event. This year, your 2018 Telephone Triage Refresher course. We do want to, before we begin, give you a little bit of background because we've done extensive development into the content of what you're going to hear today, including looking at newer evidence-based resources related to triage, and we've made some changes. So you're going to see things that sound and look a little bit different than what you've heard in the past. And some of that is also because we have, in the past, tried to teach everything you needed to know about triage in 1 2-hour session, soup to nuts. And it's just too much to tackle in that one way, once a year. So today we are going to focus on one very critical aspect of triage, and we're going to do only that. So if by the end of this you're like, hey, there's something missing, that's because there is. We did that on purpose. But that's not it. We are planning on bringing a lot more content to you in 2019, so over the next year we're going to be giving you more. So stay tuned for that. We'll give you a preview of it before we end today. So let's actually look at what we're going to talk about today. The first thing, we're not going to have much of a productive discussion about telephone triage unless we can define what it is. So that's our first task, is to figure out what are we talking about in the first place. We're also going to define something called phone screening, because they are not the same thing, telephone triage and phone screening. So we want to be clear about how they're different, and also identify why we do those things in the first place. What are we hoping to accomplish in each of those processes, so that we can be clear on that as well. And we're going to also want everybody to be aware of what their personal scope of practice is going to be with telephone triage, or in whatever capacity you're going to be interacting with patients. We're also going to move into nuts and bolts and applications. So we're going to apply the 5 steps of the nursing process to a telephone call. If you're seeing that on the screen or hearing that here in the classroom and wondering, wait a minute, 5 steps of the nursing process, I'm not a nurse. Well, I hate to tell this to you now, but you need to come back in 2 weeks, because we have a separate session for medical assistants and unlicensed personnel. You're not going to miss anything, and you can certainly stay. We're not going to kick you out, but it's going to make a lot more sense for you if you come back for that session. That's another change we've made this year, is having 2 separate sessions, one for each of those audiences. But we're going to give you some tools also to complete a history, so we'll discuss that further as we get into it. We'll also really want to emphasize the value of a complete and accurate assessment in telephone triage. We'll look at some factors that influence selecting a safe and appropriate disposition, and we are also going to do a case study at the end to practice actually taking that symptom history. So What is telephone triage? What on earth are we talking about? Who wants to take a stab at that? Feel free to shout it out in the room.
Trying to assess how soon the patient needs to be seen, where they need to be seen.
Okay, how soon the patient needs to be seen and where. We're trying to assess that. Anything else to add to that?
Triage means prioritize.
Prioritizing, right? It's a French word for sort, right? So we're sorting people into categories. What else? Why do we do triage in the first place? What do we want to accomplish?
Safety care.
It's about patient safety. Get into the right place, right? So here's a formal definition of telephone triage. Starts with a conversation, right? We're talking to the patient. That's pretty basic, but it's important to think about, right? Because it's a two-way thing. But there's also a goal to that conversation, and that goal is to assess the nature and the urgency of the patient's concern or symptom. So that means what is going on, perhaps, and how soon do we need to act on it. Right? You guys did offer up, basically the same definition, right? But then that leads to some other objectives, right? So that might lead to us giving advice to the patient. That might lead to a referral to the right level of care, and either of those things are going to happen within the appropriate time frame based on that assessment, right? But then we also talked about this thing called phone screening, right? And we do want to be clear that those two things are different. Phone screening is not just telephone triage rehashed and renamed as something else. They are different processes with different objectives. So phone screening is a systematic collection of information from the patient. And the goal is not to make an assessment, but to collect a history, to complete a symptom history. Because then that information is exchanged with the provider, who is the one who makes the assessment, determines the advice and the disposition, and then that unlicensed person can also relay that information to the patient, but they are not making the assessment themselves. So this can be sometimes hard to conceptualize. So all of you have these diagrams we're going to show on your handouts. If you're on the webinar, you should have received this by PDF. If for some odd reason you didn't get it, just email us afterwards and we can make sure you get that information. But this first diagram illustrates how telephone triage. We can see here that telephone triage is independent nursing practice. The licensed nurse owns the process from beginning to end. We discuss the problem with the patient. We make an assessment based on that information. We determine the disposition and we may give advice to the patient. All of those things are within the purview of the licensed nurse. The provider acts in a consultative role here. Doesn't mean they can't be involved, but when we do involve them, they don't need to be involved in the process. Phone screening, on the other hand, is a little bit different. As we can see in this diagram, the medical assistant acts as a conduit for information in both directions. So they can gather information from the patient, bring that to the provider, who will then make the assessment of what needs to happen next, relay that information to the medical assistant or to other unlicensed person, who will then move that along to the patient. So it's a very different process. The provider is definitely involved in phone screening. They may be involved in telephone triage. They're slightly different procedures. So that sort of begs the question of, okay, why? Why do we have two different processes? Well, that comes down to scope of practice, which is our next point of discussion. So to set us up for that, I want you to think about something. All of you in the room and on the webinar, you don't have to answer this out loud or tell anybody else your answer, but we're going to ask you to think about yourself. On a scale of 1 to 10, how confident are you that individually you are practicing to the appropriate scope of practice for your level of licensure? Think of a number, make a mental note. You can write it down for yourself if you want to, you don't have to, but just think about that. And I'm going to pass it off to Amanda Diamond, our nurse preceptor, who's going to talk a little bit more about scope of practice.
Hi, guys. So we're just going to do some questions, and you guys are going to participate in this as well. These are to challenge your thinking, and we want to provide clarity really on the various scopes of practice regarding triage. Okay, so that's what this is for. Okay, so after discussing upper respiratory symptoms of the patient, a medical assistant says, "You have no appointments here in the office today. You should go to immediate care and get checked out." What do you guys think? Is this an appropriate scope of practice for an MA?
No.
Yes or no?
No.
Okay. Well,
questions for questions. It actually depends. So that depends if the provider is the one that directed the medical assistant to go to the immediate care, right? Because as Jared said previously, they kind of are that middleman between the patient and the provider. Okay? So let's do another one regarding nurses. So after progressing through the appropriate triage protocol, the nurse determines that the disposition recommended by the protocol does not quite fit the clinical situation. She states to the patient, I don't have a protocol for this. Let me discuss this with your provider and call you back. Okay? What do you guys think? Is this an appropriate scope of practice, yes or no?
Yeah.
Great question again. The answer is actually maybe. Okay, so that depends on whether the nurse has actually obtained a complete symptom history, which is what we're going to talk more about later, and has made an assessment that the severity and urgency of the symptoms allows for that delay when we consult with the provider. Okay, so again, it depends. So I'm trying to trick you here. Okay, what do you guys think? I'm just going to take this one step further with this one. Is this above, at, or below the nursing scope? So we're just talking about nurses here. What do you guys think? Is this nurse working above, at her scope, or below? With this very little information we have here.
I think at.
Okay, it's actually kind of below. So if we are... Oh, good. It's actually below because she didn't actually make an assessment in disposition. She just consulted the provider, right? This nurse. So just a little something to think about, right? Okay. So now this, you guys actually have this as a handout. If you guys want to take out that, you can certainly follow along. This is kind of a snapshot of all the different scopes of practice in triage, really. Notice here that we added the clerical section. That is because they do have a role in this, right? They answer the phone call, the initial phone call from the patient. They identify the primary concern and also determine if it's an emergency, right? If it's an emergency, I'm sure you guys have gotten this, they come back and tell you you need to take this phone call now, or they think at least, right, that you should address that now. So that's kind of their role in it, okay? So the MA, so we talked a little bit about this, but I'm going to go a little bit farther here. They actually do what's called phone screening, and I know Jared touched on that, so I'm not going to go too far in that, but I want you to notice here where it says stop. Does everybody see that? That's because the MA cannot make an assessment of the patient's condition. Their role is to just simply obtain the information from the patient and to send it to the provider, and then the provider makes the determination on where they should go, right? Okay. And then the LPN. So the LPN and the nurse are a little bit different, just a little bit. They do what's called supervised triage. So they obtain the information. They can also make an assessment and make a disposition, but it needs to just be what's called supervised triage. That means that the LPN can make those decisions and then send it to the provider for review and final signature. Okay? Does everyone get that? Okay, good. And now we have the RN who does what's called independent triage. So they can do top to bottom, soup to nuts, right? They obtain the information just like everybody else, but they can make an assessment and a disposition, and they can actually final sign off on that note. Okay. So is everybody clear on that? So you guys will have that handout for you. And I'm going to pass the remote to Jared.
Thanks, Amanda.
Thank you.
So all that's well and good. It's good that we've had that sort of summary discussion of scope of practice, right? It's good to understand what our scope is. But what you're probably noticing at this point is as we've gone through, we've really identified that telephone triage is independent nursing practice. So what does that mean, though, right? And we're going to get into that now and talk about how we can apply that and what that means for your practice of triage. What are you going to be doing in that process? So here's a question for you all. When you're in the middle of a triage call, how do you know that your history is complete? Another way to put that might be, how can you be sure that you actually have enough information before you start making a decision or a disposition? feel free to answer that. Feel free to throw out some ideas. How do you know? What kind of criteria are you using on the phone with patients?
Triage.
Okay, so we might use protocols.
A system review.
Review of systems, okay.
We've got past, present. What's happened before with this and what's happening now.
Okay, the patient's baseline might be a useful reference point. Okay. This can be a very challenging thing to figure out. How do you know your history is complete, right? What about this? What do you do when there is no protocol? Because we all know the triage book covers everything, right? And it all fits perfectly with real life. Okay, so there's some tools we have, right? Like ABCD. Okay. Yeah, interesting. So here's what we're going to get into. Again, we want to emphasize that telephone triage is nursing practice, because what this means for you as licensed nurses practicing telephone triage is that you are legally held to a certain standard of care, and that does not matter whether the patient is physically in front of you or on the phone. So you're held to the same standards of care, and that basically is to follow the nursing process. Those 5 steps we all got drilled into our heads in nursing school, right? So what we do, the performance of triage and our documentation really should reflect that 5-step process. But here's the funny part about that. It's like, did anybody here actually learn that in school? How to do that over the phone? Anybody teach you that? Because if you did, I'm jealous. I want to go to that school. But how do you do that over the phone? We all learn this in a bedside role, right? I'm not going to run through what the 5 steps are because we all know it. We're all nurses here, right? But it's much easier in a bedside role, right? When we talk about assessment, we can see the patient. You can use all those physical examination techniques that we worked so hard to learn and practice to actually see the problem. And then your actual diagnosis, you can name the problem because you can see it, right? When it comes to planning, it's identifying those interventions that we can perform, and then the implementation, we actually can carry out the plan of care. We're used to doing a lot of that care in a bedside role. Evaluation is pretty easy too, because all it means is go back in and reassess the patient, see where they are compared to where they started from, right? But then you talk about doing it over the phone and it gets a lot trickier, right? Because when we talk about assessment, the patient isn't in front of us anymore. We don't have any of those tools that we learn to use. All we have is a history. That's the only tool we have. Actually, sometimes you can teach the patient to assess themselves, like take their own pulse, for instance, but that's pretty limited, right? And it really doesn't give you great information all the time. So it isn't, we can't rely on that. So it's all about our history. And then we can't even name the problem, really, because we can't see the patient. We can't see what's going on. All we can do is figure out, okay, how soon is this going to potentially harm or kill the patient? And what do we need to do about it, right? Planning is about identifying where to send them, what kind of resources they need, and what logistically is going to get them there, right? And then implementation, this may be the hardest part for us nurses, is that we can't actually do anything. Right? We can't make the patient do anything. We coach them, we instruct them, we need to get their buy-in and agreement for them to even do any of the plan of care we come up with them, right? And evaluation is tricky too, right? You can't go back and assess the patient again unless you actually do that. Like, you have to facilitate that somehow. Either create a contingency plan, tell them what to do if things change, right? We may even have to initiate a follow-up call to reassess where that patient is, right? That's how we would do that. So those are the sort of 5 steps distilled into that phone setting where it's a little bit harder to do it, right? But to emphasize really where we're going to focus our attention today, we're going to read you a little story. Lisa Lang, my colleague, is going to read that for you. And we want you to think about what step in this 5-step process was missing or incomplete in this scenario.
An elderly gentleman visited an urgent care clinic for evaluation and treatment of gout, for which he was placed on indomethacin. He took his first dose that evening and his second dose the next morning. Shortly thereafter, he began vomiting and called the urgent care clinic to inquire about what he should do. The nurse, assuming the problem might have been related to the indomethacin, asked him if he had eaten breakfast before taking his morning dose, which he had not. Assuming the patient's GI upset was related to the indomethacin, She advised the patient that indomethacin can be hard on the stomach and to be sure to eat before he took his next dose. He then inquired about what he should do for the associated pain in his throat, for which the nurse recommended acetaminophen, once again, assuming the throat pain was related to the vomiting. The patient was dead 1 hour later, secondary to an anaphylactic reaction to indomethacin.
Okay. So what didn't we do? We didn't assess the patient. I heard a lot of assuming going on in that story, right? Good rule of thumb is if you're assuming anything, you didn't assess the patient, right? So it's so critical, right? It's the first step for a reason, because if we don't get it right, if we don't have a good, accurate, and complete assessment, none of the other steps matter. It doesn't matter what you do after that. So that's what we're going to focus on today, is how on earth do you actually assess a patient over the phone? And we talked about earlier how the only tool we have at our disposal is our history. But unfortunately, a lot of us haven't had as much practice with those techniques as with the physical assessment techniques that we learned. So we're going to give you some tools today. So how do we actually do this? Well, we're going to give you two tools, two mnemonics that you can use, one or the other, as a mental checklist to take your symptom history, to organize it, make sure it's complete. This is what's going to help you understand when you have enough information to move forward in the triage process. And so it's something that's going to be really useful to you. You're going to have it in a handout, and again, you could have received this in PDF if you're on the webinar. And we'll refer to that as we go along. There's two options here. One, memorize both. They are the same ideas organized a little bit differently. So either one is fine, whatever one makes more sense to you. So here they are. There's this word old carts and this other word phosphate. And the letters in those words stand for various components of the history. And you'll notice that a lot of the same information is existing in both of these, and that's why we tell you not to use both. Just think of one that makes most sense to you. I personally tend to find old carts makes more sense to me, so that's what I use. But everybody may be a little different on that. And you'll notice that a lot of the same information is there. So things like, when did this start? What kind of pattern is there, right? Is it something that's intermittent or gradual, or has it been around the whole time? Does it persist? What kind of things bring it on, make it worse, make it better, triggers, right? Are there other symptoms? This is a super key question here, right? Because we all know that the first thing the patient calls us about is not always the thing that's going to kill them, right? The patient who calls with a cough but also has chest pain, arm numbness, and shortness of breath, right? But they didn't mention that until you ask. So that's important, right? If we miss this, we could miss the real reason the patient's calling. So again, we use this as a mental checklist as we're taking our history. Some of you might be sitting there thinking, wait a minute, whoa, slow down. I thought that we were supposed to use protocols. You are. We use both. But where do they fit in, and why? How do we use each one of these? Well, the first thing that we should be doing in a triage call is taking that symptom history. We're going to use this mental checklist first, because isn't it true that when we get the patient to spit out that narrative, none of it's organized, right? So this is your tool to help organize and clarify that history. As the patient spits out that, that story of what's happening, we're going to use this to keep coming back to and make sure that we have that information, the key components, and that we've answered all those sort of questions in our head about what's going on. This is going to improve the accuracy of your protocol selection, and that is why we do it before we even open the protocol book. Because if that patient is calling about a cough, but they're really having chest pain, arm numbness, and shortness of breath, you don't want to be on the cough protocol. You want to be on the chest pain protocol. And you only know that if you have a symptom history before you go there. This also prevents using the protocol blind. What do I mean by that? Anybody want to take a stab at that?
Like no one, I was talking about what it is.
Okay, that might be
Without
one
opening
way.
the book.
What's another way we could use the protocol blind? Okay, always want to avoid making a medical diagnosis.
You must remove the human factor part of that, because you're just going by the questions and answers, not using your own nursing intuition.
Right, that's exactly what we're talking about, is whipping open that protocol book and reading those questions off from start to finish without doing this first, having that history. Because this not only makes it so that it's more accurate, it makes it more efficient, because the real way that you're supposed to use a protocol is to bring that in to complete the history. So we scan from the top to bottom, and we ask the questions that we have not already answered in the history, so that we're not omitting things. The triage protocol is a decision support tool. It does not make the decision for you. So remember that, and that's where this fits in. We do the symptom history first, then we bring in the protocol, and you'll find that it's actually more efficient that way. You're quicker with your calls because of this. So that might be a little bit new, so we'll practice that later, but something to think about. Now, we're not going to cover protocol use today because that's kind of another topic, and there's a lot in it. We also know that you all use protocols and you are comfortable on some level using them. So once you've done that process, you have your history, you go through your protocol, oftentimes the hardest thing to do is figure out what to do with the patient, right? Where do they go? Especially when it's not cookie cutter and it doesn't fit the protocol well. So we're going to give you a series of questions you can ask yourself as you're going through that process to make a better decision. So first thing you want to think about is, what is the worst case scenario? What's potentially going to kill or harm the patient? And then closely related is, what is the shortest time frame in which that might happen, right? What's going to kill them and what's going to do it first? Next, you want to think about, what do we need to do, right? What kind of tests, what kind of imaging, what kind of procedures might need to happen in the workup or treatment of this complaint, right? So this is a resources question, right? Closely related, the next thing is, okay, where is that, right? So if your patient needs a CAT scan, you need to know where the CAT scan machine is so you can get them there, right? So that's something to think about in terms of your disposition. How are they going to get there, right? Can they safely drive themselves? Do they need EMS or life support? Those are things to think about, right? And then particularly when the decision is to delay care, do they actually know how to get to or access care? That sort of healthcare navigation piece, the care coordination, do they have the right phone numbers? Do they know, how directions to get to another outside provider, for instance? These are things to ask yourself while you're going through that disposition process. Now notice that this requires quite a bit of background information, right? If you don't know what the worst case scenario is clinically, or you don't know how quickly that could happen, or perhaps you're not really sure where the stuff is that needs to happen, or even what needs to happen, those are knowledge gaps that you may need to remediate on your own. So if you've come across that in a call, good opportunity to pick the brains of your providers and your colleagues, right? Reach out to us in the nursing department. We have resources that can help you self-study and learn these things, right? Because that's what's going to make you a better triage nurse, is building up this knowledge base so these answers to these questions come quicker and you make more intuitive decisions. So, we are coming to the fun part. We're going to practice doing this. So you all have your handouts with your two mnemonics on them. That's what we're going to kind of use for this. So this is focused on actually the symptom history. So I'm going to hand it off to Amanda, who's going to handle the case study, and we're going to ask you all to participate to the best of your ability.
All right, so if you guys want to take all your handouts out. So we're just going to apply some of the things that we've learned with this case study. So we have our patient, Mike. Mike might look a lot like Jared Karen, but we're going to go with Mike, okay? So Mike is 43 years old. He takes no medications. He doesn't have any allergies, and he has no significant past medical history. He is just the perfect person, right?
Or I never went to a doctor.
The phone note states he's complaining of a cough. Okay. So now, how am I going to initiate this conversation with Mike? Okay. What do I want to ask him?
Tell me a little bit about your call.
I love that because it's nice and open-ended, right? We want to start with an open-ended question. So now I call Mike and I say, okay, tell me a little bit about your cough.
Well, I don't know. I've been like coughing nonstop for like a week now, just actually even more than a week. And I was just wondering if Dr. Brady could call in a prescription.
That's wonderful. He's not the perfect patient anymore, right? So is that, go ahead.
First thing I'm going to note is he's speaking in full, complete, clear sentences without difficulty, so he's breathing.
He's breathing. I mean, that's good.
Honestly, that's where I want to start.
Absolutely.
Could be many different things.
I'm not the best actor.
He is, absolutely.
Most likely.
Absolutely.
Yeah.
So is is that and this information enough for me to make a disposition safely in a way? No, right?
But it
So,
just means I don't need to call 911 right now.
at this very
I haven't
moment.
ruled it out.
We haven't fully
I
ruled it
don't
out.
need to do it right now.
But we need to ask him maybe a little bit more information, right? So what tools would I use to do that? Okay, your handout?
Yeah, how long?
We'd wanna use our handout, right? We wanna use old carts or phosphate, right? I also actually prefer old carts. It's just something that I've learned and I kind of just go with. So let's focus on old carts first.
So he already told us that it's started about a week and a half ago.
Okay, about, right? So maybe we wanna get a little clearer picture of
I
that.
can't remember, like, any events that associated, like, can you think back to a week ago, were you at a friend's house, you had a party, like, where were you, can you think back and try to tell me a little bit better when
Yeah.
exactly that started?
Yep,
Yeah.
absolutely. So
Before the weekend, that's.
what if right, so if he says last weekend, it's Tuesday today, right? Was that this past
So
weekend
not
or was
this
that a week
weekend.
ago?
It was like sometime, like, I don't know, maybe Saturday, maybe Sunday, last weekend.
Did you have a cold? So about 10 days ago, right? We want to try to get a clear answer as best as we can, right? And I don't know if you guys have noticed in that triage form, there is an approximately button, which we can certainly click, but we really want to try to get a good understanding of when this truly started. Okay, so let's say it's 10 days ago. So now what else are we going to ask him? Following old cart?
Is it a dry cough? Are you getting any expression at all?
Okay, so is it a dry cough? Okay, so maybe that goes with the characteristics, right? Is that what you're trying to? Okay, so that goes with the characteristics.
Yeah, it's definitely like a dry hacking cough. I'm not coughing anything else.
Done any chest discomfort with cough?
No, my chest fine.
Have you had any fevers?
No fever.
Okay.
No,
And let's try to.
I don't know that I have a fever.
Let's try, yeah, so we're jumping around a bit. Let's try to stick to the old cards, right? So we got the onset 10 days ago, right? And we kind of jumped down to characteristics, which are, can anyone tell me?
Can I interject back to onset real quick? I would always ask too if he's had any recent, like, air travel or been sitting in the car. Like, was it around somebody that was just to the onset?
That's surrounding.
Like, okay, it was 10 days ago, but were you doing anything 10 days ago?
Right.
That I need to be concerned
Or you're
about?
around with anybody 10 days ago?
Or, right, that had the
Right.
similar symptoms, right?
Were
Did you
you
go
in a
to
house
a
fire?
party or a house fire?
Feeling onset.
Were you in California?
Okay, so let's kind of jump back up here. Okay, so we have onset. What's next? Location. Where is this happening? Yeah, cough, right? It's in his chest. Absolutely, but maybe that isn't very beneficial with this in particular. So maybe we can put it in the chest, right? If we want to. Yeah. So let's go to the next one because maybe that one is kind of strange to put in our note, right? In the chest. But if the patient had chest congestion as well, we would put chest congestion, right? What else? What's next? Right. How long has it lasted? Patient last?
I don't know. It's not like I don't cough all day. It's definitely worse at night.
Okay.
Is it keeping you awake?
Oh yeah, I'm not sleeping well.
I like that question.
Yeah.
Because that's now affecting his daily activities, right? Absolutely. What else would we ask?
Have you taken anything for it?
Like that too?
Yeah, I found some stuff in my cabinet. I think it's called Delta. It's in an orange box. I don't remember exactly what it was, but I drank some of that stuff. Wasn't even sure how much to take. I just kind of took a swig.
You sure it was Delta and not something else? Yeah, right.
Did it help?
And did it help?
Not really.
Okay. Does it increase with activity? Good question.
No, not like noticeably, or at least I'm not paying attention to that. So.
I told you he's not a good patient anymore.
Does anything seem to make it worse?
I like that, yeah.
Oh man, I can't lie down flat. Like, it's so much worse when I lie down. That's why I can't sleep, because I can't lie down. So, and I can't sleep sitting up.
describe the cost? Parking, production?
It's like a hacking kind of like, I don't know. I can't explain noise. No.
That's definitely something.
Anything besides this?
No nasal congestion.
Good, because that goes to the
My
other related
nose is
symptoms,
fine.
right?
Yeah. You know, if this was a real triage patient about that, you'd be complaining, that's why you're asking me all these
I know.
Yeah.
Yeah.
Oh, yeah.
That's right, something. Let me direct you back again.
Yep, so
I
then
mean,
you'd have to
going.
bring them
Never
back.
done this before, so I have no point of reference.
So you'd want to bring them back, right? You want to try to steer the conversation back to answer the questions that you need to answer.
Any blueness, the lips, the bed, the nail bed?
I haven't looked in a mirror.
Wait, what was that question?
No idea. My nails are fine.
Any blue,
Oh, okay.
blue in
I
the
don't even think
nails?
I have a mirror. I'm a guy.
Oh, my God.
Take a selfie.
Have you had?
You got a phone, don't you?
So are we down to, are we related to them?
So we kind of jumped around a little bit. So, we did start to go into other related symptoms with the sinus stuff, and then we kind of jumped to, going back to the chief complaint. So let's go back to the other related symptoms and rule some things out, right? So we ruled out sinus and yeah, fever, I think someone else said.
Do you have
How
any
about vomiting?
shortness of breath or difficulty breathing?
That's a good one.
Like, not all the time, but I get these coughing fits, and man, in the middle of that, I can't catch my breath at all.
Are you having any swelling
A lot of people want
anywhere?
to smack me. Am I having what?
Swelling, any swelling?
Swelling? No, my legs are fine.
Seems like numbness in the ends of your feet.
Nope.
Okay.
You think?
Chest pain? Chest pain's a good one too, right? Cough, chest pain,
Yeah.
absolutely. Sometimes people have pain in the ribs when they're coughing.
back?
It only hurts when they
Not
cough.
really.
Yeah, in the back.
Like, it's not comfortable to cough, but I don't have chest pain. Like, I'm not,
Okay.
Slow throat?
only when I've been coughing for a long time.
Okay, so I think we got a pretty good picture around, what's his chief complaint anyway, right? So what's next? Home treatment, so we found out that we discovered that he thinks he took Delsum because it was an orange box. So maybe we want to get a little more clarity there, but, I'm gonna say he took Delsum. And then what about the last one there? I think that's maybe the only one that we didn't get to. Do you guys agree? Or is there more, do you feel?
Well, I would ask, you have coolness humidifier running, is your head of your bed elevated?
Yes, absolutely. So that's the alleviating, aggravating type of symptom. So what helped? Did that humidifier help at nighttime? Because that's when it's the worst. Absolutely. Very good. Yeah, maybe more to the home care things they've been doing, other treatments they've been doing. So it kind of goes into the treatments as well.
And actually, I just want to know if this has ever happened to them before.
Okay. A cough?
Yeah.
Okay.
This type of cough, yeah.
This type of cough?
Have you run into this before?
Ooh,
No.
yeah. Maybe we want to find out that if he has asthma.
Or allergies.
Or if he smokes. Very good information. Yep. You guys got a good picture.
How might we ask about severity?
Yes, so let's jump to the last
This
one.
is an important thing to think about.
Well, is it interfering with you? That's the best.
Yeah,
Interfere with your
So,
daily activity.
exactly.
absolutely, I'm going to repeat that just for the webinar people. It was offered that we would qualify how severe the symptom is by comparing how is it interfering with daily activities. This is absolutely critical. This is how we determine severity of symptoms in a history over the phone, is that baseline comparison. There are some symptoms you can quantify, like pain. You might be able to get them to give you a 1 to 10 score sometimes. But usually it's more effective to find out what's the functional impact. So that's a good way to ask about severity of just about anything. Like what are you not able to do today that you normally can? So
And
good
we've
thing to think about.
determined that the sleep, it affects the sleep. And maybe we could look a little bit more into that. Are you able to do your chores around the house? Are you going to work? Yep, exactly. Is it affecting work? Is it, Mr. Mike?
Well, not sleeping, so that makes it hard to work.
Oh, okay.
Not sleeping.
So it is impacting work, right? So it is. So it's
That's why I'm on a
impacting.
prescription. So I can go back to work.
You need a prescription.
Or no.
So do you guys feel good with that? Okay, I do too. We have a lot of information, a lot more than what we started with, right? And we had all said earlier that this information wasn't enough, right? Just, oh, you had a cough about 2 weeks ago or about 10 days ago, something like that, right? Now, how about this? 10-day history of non-productive hacking cough, so we have a descriptor there. Gradual onset, worse at night and with laying down. Associated shortness of breath with coughing. This only has tried over-the-counter Delsum, that orange box, with no significant effect, so it didn't help. Cough is impacting sleep and work performance, and is requesting antibiotics. Okay, so which do you think is more valuable to help you make a disposition, or before that even, determine what protocol you should use?
Well, is he actually asking for antibiotics? Does he want something for his cough, like with a narcotic?
Well, a lot of times they want an antibiotic before they're even evaluated to determine if they actually need one.
True, we didn't clarify.
But we did not clarify.
Our bad.
Sorry. So this is a much better picture, right, for us to proceed with the rest of our triage call. And it might make going through that book a lot easier, right? So it just shows the value of taking a good symptom history. And you want to use that for your symptom history, right? Your old cards, I can't see that one, and phosphate, okay? So you can just, like Jared said, just choose one or the other. Both are sufficient, just one or the other. Okay.
One quick word about the related symptoms. So the goal in the symptom history of that segment is not to dive into the screening of ruling out yes or no's. It is to identify if there are secondary complaints or perhaps primary complaints that just weren't mentioned, right? So the example of the person with the cough who actually has chest pain and shortness of breath, arm tingling. So you want to go into that section with an open-ended approach. What else is happening at the same time? What other things are going on? Is there anything else that's bothering you right now? Because the person may not be connecting the two. They might not be connecting their headache and their nausea and vomiting together, right? But they are happening. So the idea is to identify so that we can figure out where do we need to go with this. Not so much to rule out specific things. That's where the protocol comes in and helps you. So there's a difference between those two. And we're very used to that sort of yes or no approach to triage, but there's a role for both of those things. So it's just something to think about.
So Jared's going to take it away with the takeaways.
Yeah.
And you guys did a great job.
Yeah, excellent work on the case study.
Yes, very good.
That is, obviously, we kind of slowed that down a little bit. Your triage call may be a little more smooth and coordinated. But we did want to summarize what we talked about, because even though we've only talked about one piece of this triage process, we've covered a lot of ground today. So we want to kind of summarize it for you so you have some concise things to bring back and some things you can do today to improve your own triage practice. So we discussed the definition of telephone triage. We're having a conversation with the patient, and the goal is to assess and prioritize their concerns, make an appropriate and safe disposition, and then to give timely and accurate advice. We talked about how there are two different processes because of our scopes of practice. So medical assistants practice phone screening by gathering clinical data, communicating that to providers, and then communicating their advice to the patient. We also discussed how licensed nurses practice telephone triage by making an assessment of the patient, determining the disposition, giving advice, and that the LPN requires supervision for that process. But it's very similar when we look at it in practice. What can you do today, tomorrow, over the next year to improve your triage practice? Well, practice doing what we did today in the case study. Take that symptom history systematically before you select a protocol. It might come a little bit unnaturally if you're used to jumping into the protocol right away, but stick with it. It will get more efficient. It'll become second nature, and you're going to notice that it makes you more efficient. Use the tools we gave you today, the old carts or phosphate mnemonic, as that mental checklist as you complete your history, so that you can gather sufficient data before we start making decisions. Use the triage protocols after that to complete your history. Use them as a decision support tool. That's what they're meant to do. So you'll use that, find those questions you have not answered yet from top to bottom, and then clarify where that patient needs to go. You're going to find that by the time you get here, you already have an idea what you're going to do. So it's going to make it much faster and more, you're going to feel a lot more confident in your triage as you get good at this process. And then as you decide that disposition, really try to identify what's the severity, how life-threatening is this, and how urgent is it that we act on it as you decide that, because it's going to make that decision much easier. It's going to drive your disposition. So like we said, this still probably feels incomplete. There's a lot that we didn't cover. We didn't cover anything about protocols. We didn't talk about documentation. We are bringing that to you in 2019, we promise. So the next thing we're going to cover is protocol use. So that is going to be coming soon. How do you use a protocol? Where does it fit in? How do you even read the page correctly, right? That's all coming in 2019. We're really excited about it, so stay tuned for that. And just know that there are going to be a lot more options for you to learn about triage as we move forward, because we know there's a lot to unpack in this topic. These are the numerous references we used for this presentation. Also a reminder for those of you who actually want to get credit for this towards your license renewal, it is eligible for a contact hour. Do make sure you sign in. If you're here in the classroom, the paper is going around, just make sure your name's on that. And also, if you are on the webinar, make sure you give us your names in the chat box so that we can catalog those and get you your stuff. But then you're not done there. You have to complete an online evaluation. There's a deadline on that. So it has to be done by the 31st in order to get your contact hour certificate. Also, key thing, this is the last time you will see this link. So if you've attended today and you want that contact hour, you might want to write that down so that you have that and can complete the evaluation. Once we get your evaluation, then we will send the contact hour certificates after the evaluations have been collected. So, and if you have questions, Julie Sampson, our project manager, is more than willing to answer them about this process.
Where is that piece of paper?
What's that?
Where is that?
The evaluation?
No, this whole thing.
Right there.
Right here.
Oh, only
Right there.
here.
That's, yes.
Right there, yeah.
This is the reason you have to attend to get
Feel free to take a picture with your phone.
Yes. We know you're here.
Yeah. That will be much easier.
Question?
I do have a question.
Yep.
So I was charge nurse for long-term care for like 10 years.
Yep.
So you can tell that the visual assessment is very, you know, in my head. And I just started doing triage calls, and I'm a little confused because I am cardiac. Is when, as an LPN, do I have the ability to tell that patient on the phone, I think it's in your best interest to go to the emergency room?
You always have that ability. Okay.
I do not have to seek out a RN or a nurse practitioner or...
So supervision is defined rather loosely. So always act in the best interest of the patient when in doubt. So like you don't want to be running around looking for somebody to sign off on that decision while the patient is potentially in a life-threatening situation, right? So act in the best interest of the patient, and the supervision in our institutional definition is the provider reviewing your note for completeness and appropriateness and signing it. So you don't need to necessarily have that. As a nurse, you do have the ability to make a decision. It's just what happens after the fact that generally takes that into account. That being said, as a licensed professional, it's our responsibility individually to know when we're in over our own heads, right? So when you're like, you know, I really don't know what to do with this, that's a good time to get a colleague, right? And usually you want to go up the chain of scope of practice when you do that, so that you have some supervisory role there. But you don't need to involve anybody, or else that would be phone screening. You had to bounce off somebody before you did it. Other questions? Now's a great time to do that.
What was the disposition?
What's that?
What was the disposition for Mike?
We don't know yet what our disposition was for Mike. We didn't use the protocol yet. We don't know that yet. We haven't finished the process.
Hang in there, Mike.
Sorry, Mike.
Don't worry, Mike's very healthy. He's going to be fine. It tastes good. Great flavor. Any other questions?
Are you going to focus more on pediatric triage too? Because that's a whole different world.
So the principles of effective triage are the same in both environments. Okay. The the difference of what kind of complaints you're gonna get is gonna be different. Oftentimes, pediatrics are gonna be operating through a third party. We're gonna cover a lot of that stuff over the next year. So we'll talk about protocol use next, and we will address both the pediatric and the adult protocols. Okay. So that is gonna be covered, but we aren't gonna get into like clinical pearls until we get through a lot of other necessary things. So there will be tools and pearls for everybody in all of these coming sessions when we go through it. So we're trying to make this as practical and useful for you as we possibly can, no matter your specialty.
Okay. Any other comments?
Thank you for joining us.
Thank you.
Thank you.
Have a great day. Thank you.
Should we mute it so they don't have to hear all of us like rattling around?